Our first speaker this morning is Dr. Margaret Gourlay. Margaret's assistant professor at the Department of Family Medicine, University of North Carolina at Chapel Hill. She has an interesting background in that she's, I don't think it has, I think she also got a veterinarian, doctor of veterinary medicine also, but she was a BS at University of Iowa, Master's Public Health at University of North Carolina, received her medical degree at Rush, and then was a resident at UCS San Diego. She did a fellowship at Georgetown University. She's been listed in the best doctors of America, and then she received a doctor of veterinary medicine at the University of Iowa also. And she's going to talk this morning about this article she published in New England Journal about osteoporosis screening. Margaret.
Thanks to Dr. McLean and the program committee for inviting this talk. As you can tell by the introduction, I am a bit of a misfit for your conference, but my team published some data last January about an osteoporosis screening interval, and Dr. McLean wanted you to be aware of it. It is new information in the field, and we will cover that, but since we have the whole hour, I wanted to cover some fundamentals of screening first, so you understand the setting for the new results. By the end of the hour, I hope you're more skeptical about current osteoporosis screening practice, because we are far behind other screening programs in the quantity and quality of supporting evidence. I have no financial conflicts, but my disclosure is that when I practiced the talk, it was quite a bit too long, so I'll be skipping a number of slides or just going briefly through some of the slides. I apologize if that's distracting. These are the main topics we'll cover, which are all very basic. And we'll start with general evidence for osteoporosis screening. This is the definition of screening from a real skeptic in this area, David Sackett. He defines screening as the early diagnosis of pre-symptomatic disease among well individuals in the general population. The key phrase in that statement is well individuals. These people are fine before we test them for a disease. And even if the test is negative or normal, we change that patient's thinking a little, and we change our own thinking about it by running the test. This is why screening in people who don't have symptoms is a challenge. If we cause any adverse outcomes, worries over a bone density T-score that's fine for age, renal insufficiency from an IV bisphosphonate when the patient would not have fractured. If we do that, then we create a problem where there wasn't one before. So remember that screening is that two-edged sword. We can't just look at the benefits, we also have to look at the risks. And we need to weigh both before deciding if screening is useful. We'll go quickly through basic information on the background. We know that fracture is the important outcome in the screening program. We largely focus on bone density testing and osteoporosis, but fracture is the definitive outcome. Osteoporosis itself is painless, and for patients who never have a fracture, osteoporosis doesn't matter. Fractures are in large numbers in the U.S. They cost the healthcare system large amounts of money, and the mortality rate is high. So fractures, especially hip and spine fractures, are something we want to prevent rather than deal with later. This graph shows how the rate of hip fracture for women rises almost exponentially after the age of 70. Because of these trends, osteoporosis cohort studies and clinical trials internationally were mostly conducted in older postmenopausal women. This is the most common query we had on the osteoporosis screening interval paper. Why didn't you analyze fracture, time to fracture? And why don't we screen for fracture? The difference between fracture and these other screening targets, breast, colon, and cervical cancer, is the lack of a safe and predictable preclinical or early stage of the condition. Those of you who know bone research are already thinking, what about morphometric vertebral fractures? Those are spine fractures found incidentally on x-rays, not diagnosed clinically. That's still not the same because you can remove the DCIS, the colon polyp, or the cervical tissue with atypia, but you can't remove the deformed vertebral body and get a cure. Instead, we screen for osteoporosis because the spine is not deformed yet, and prospective